Hello, sir.
Hi.
Now, would you mind if I examined your heart?
That's all.
It's going to involve me listening and also checking your hands, your pulse, and so on.
Yeah.
All right?
Okay.
I'll just pull this down for the moment.
Thank you.
You've lost a finger in an accident, was it, sir? Okay. Let's have a look. Okay. I'd like to raise your arm. Do you have any pain in your shoulder?
No.
Okay. Okay. That's fine. I'm going to look in your eyes, so just look up to the ceiling. That's good. And show me your tongue. Okay, that's fine. Now look up to the ceiling on the other side. Okay, I'm just going to press on your tummy, sir. Good. You can look where you like now. Okay, can I ask you to roll onto your left side now? Okay. This arm across there. Good. Okay, and now sit forward for me. Breathe in, stop there. Breathe out, stop there. Breathe away and chin up for me. I'm just going to press on the side of your neck now. Okay. Okay, take some deep breaths in and out through your mouth, sir. Okay, that's great. This gentleman is comfortable at rest, and he has no scars to indicate previous cardiac surgery. The salient points to note are a pansystolic murmur at the apex, which radiates to the axilla, and an early diastolic murmur, which is best heard at the left sternal edge with the patient sitting forward and in expiration. The apex itself is displaced to the sixth intercostal space in the anterior axillary line and is forceful in nature and is accompanied by a left ventricular heave. However, venous pressure is not elevated, there is no peripheral edema, and his chest was clear. These findings are consistent with combined cardiac pathology of mitral regurgitation and aortic regurgitation. The important points to note in this case are that this gentleman has evidence of both mitral and aortic valve disease. So you need to be able to demonstrate to the examiner that you found the features of mitral regurgitation, which is a pansystolic murmur that radiates to the axilla, and of aortic regurgitation, which is an early diastolic murmur, often heard at the left sternal edge and with the patient sitting forward. You then need to make an assessment of the severity of both of these lesions, and it can be complicated with two regurgitant lesions in any one patient. For mitral regurgitation alone, the displacement of the apex would indicate left ventricular dilatation, which is a marker of severity of mitral regurgitation. The same applies to aortic regurgitation, and in this case, the displacement of the left ventricle, as evidenced by movement of the apex to the sixth intercostal space, may be because of one or either or both of those lesions. With aortic regurgitation, another useful peripheral marker of the severity of the condition is the character of the pulse, which in this gentleman's case was normal. It wasn't a collapsing pulse as you sometimes find. Overall, the effect on the ventricle can be assessed both by its enlargement and by the fact that a third heart sound in this case indicates that the left ventricle is volume loaded from both regurgitant pathologies. And in such cases, both symptoms and left ventricular dimensions and function will dictate the move to surgical correction of these pathologies. The indication to intervene surgically by replacing valves on such patients depends on symptoms and our clinical and echocardiographic assessment of left ventricular dimensions, or in other words, an assessment of how the ventricle is coping with the valve pathology. In mitral regurgitation and aortic regurgitation, if taken separately, the key feature is the functional capacity of the patient and what their symptoms are, which are predominantly breathlessness on exertion. Clinically, markers of left ventricular enlargement include displacement of the apex, and markers of volume overloading include additional heart sounds, third and fourth heart sounds. On echocardiography, we tend to consider 5 centimeters as an end systolic diameter as being the indication to refer people for surgery for mitral regurgitation, and 5 to 5.5 centimeters of end systolic diameter in aortic regurgitation. The degree of ventricular embarrassment is almost more important than the degree of mitral or aortic regurgitation itself.